So welcome everybody. I am Angela. I'm just letting a couple more people in. So I am Angela and I am the State's Advocacy Director for Compassion and Choices. So thank you so much for joining us. And I am also delighted to be joined by Marcia Sloan. She is a Compassion and Choices storyteller and a volunteer with us who lives in Northern California. And she's also going to help me present today over some of the end of life options and share her story with you all. So, the goal of Train the Advocate is to help advocates feel comfortable having meaningful conversations, learn how to present in your community about end of life options, and to grow the movement. So, if you do not want to give a presentation in your community, don't worry. Marcia started off coming to Train the Advocates, and she is going to be presenting with me today. But I don't know that she's done presentations in her community, but she has really gotten into this, has become, she was just sharing with me that she started end of life doula training, and she is kind of spread in her community as the go-to person for if they have questions about end of life and advanced care planning. Who should they go to? And they all kind of go to Marcia now. So really, this can also just be about getting information and education for yourself as well. So we also offer multiple Train the Advocates throughout the year, and we hope that you'll attend them. So this is the second time I've done Train the Advocate 101, which is an overview of compassion and choices and end of life options. I did another training in January. So sometimes we have volunteers and supporters who like to take multiple trainings. I myself like to do that so that I, feel more comfortable with it. And then you can ask different questions. And I like to listen to the other questions that people ask too, because it's not stuff that I maybe thought of, but then might come up when I'm out talking to people. So you feel free to take this class as many times as you want, as well as the other courses that we're going to be doing throughout the year. Today, I'm going to also be speaking to you as a presenter. So if you want to present in the future, this is how you could do it. And then also as a mentor, so giving you tips on how to present and have these conversations. So a few tips before we get started. I want to go over a few technical details. So during the presentation, please keep yourself muted and silence your cell phones. We'll have time for question and answer afterwards. And this presentation is just for general information. So if you have specific questions about your personal situation or a friend's personal situation, we can also connect you to an end of life consultant. So if you are ever out and talking to people, or if you're giving presentations and somebody asks you to, my dad has this specific illness and what should I do? Um, just know that it's never on you. This helps me a lot to think this way. It's never on me to provide this information. I can always connect them with the end of life consultant if I'm not familiar with it. And just a few group agreements. So Leslie is going to be helping us too. So if people are coming off mute and we're getting like feedback, she'll help me pop around and mute people. So if you get muted, that is her doing that. Use I statements. So always speak from your point of view. Life happens, but try to minimize distractions. And then build upon and try not to repeat what others are saying. Allow for equal airtime. So move up and move back. And then you can ask questions either by raising your hand or writing in the chat. And you can also just take yourself off mute. Sometimes we get a lot of people on these and I can't see if you're raising your hand. So again, when we get to the point at the end, feel free to take yourself off mute and just ask a question. So we always start every presentation that we do with our mission statement. So Compassionate Choices is the nation's oldest, largest, and most active nonprofit that's working to improve care, expand options, and empower everyone to chart their end-of-life journey. So what you see on the screen right now is the mission statement. We believe in patient-directed care, where patients should have the ultimate decision of choosing treatments that align with their individual priorities. Patients and healthcare providers should work together as a team. Your healthcare team should not be making decisions alone. And then this is just a snapshot of Compassion and Choices. So we are active in all 50 states, plus Washington, D.C., Puerto Rico, and Guam. We have over 450,000 supporters nationwide, almost 9,000 volunteers nationwide, over 70,000 active donors, And this is a little outdated. It says we almost have 100 employees. I think we're at 107 right now. And we have a top rating from 5 major charity watch groups. And then just to give you an overview a little bit about Compassion and Choices. So we have a lot of different departments. We have different services and programs. So I'm going to talk about a few of them here, but I also encourage you to look at our website to find our full scope of work. So as I mentioned earlier, we have the end of life consultation program. So we have end of life consultants that offer free information and resources to individuals across the country. So this isn't, it doesn't have to be just your personal questions about yourself and your own health. If you have, questions about a loved one or a friend, you can call on their behalf and just gather some information and resources that you can provide to them too. So end-of-life consultants can help with things such as helping explain end-of-life options, advanced care planning, things to consider when choosing a hospice, how to navigate the healthcare systems, and more. They also have a translation service, and they can offer these services in over 200 languages. We have an end-of-life planning resource center on our website, and some of the resources on that website we'll go over today. And then I am part of our advocacy and outreach team, and we work with volunteers to, Compassion and Choices is really a grassroots effort. So we work with volunteers across the country, and they'll help us pass legislation. And then once the legislation is passed, they'll help us try to hold community events or go table in their community to get this information out to the community about end-of-life options and resources. And even in states where we're not actively trying to pass legislation, it's just as important for people to have information on all of their end-of-life options and resources available. So we have volunteers out doing presentations and tabling events in those areas as well. So while everyone at Compassion and Choices also works to foster a diverse and inclusive movement, we also have a community engagement team, and they specifically focus on working with specific populations to promote health equity at the end of life. We also have a clinical education team. So these are healthcare professionals, and they provide trainings, resources, and information to other healthcare providers. So a lot of schools don't teach a ton around end of life, and definitely not some of the end of life options that we also provide and help pass laws for. So our team will go out and try to educate and provide that information to other healthcare providers as well. So we also know that the power of personal stories inspires and drives change. So if you have a personal story about end of life, which you probably do since death impacts us all, we'd love to hear from you. And then we also have a philanthropy department. So 96% of our funding comes from individual donations, and that supports all of our efforts that we do. So research has revealed that most people want to experience at the end of their life, they want to be at home with their loved ones. They want their pain and discomfort managed. They want to have their spiritual needs and values respected, and they want to do it without being a devastating burden for their loved ones. However, in reality, what happens is 60% of Americans die in acute care hospitals and another 20% in nursing homes. And then 1 in 3 near the end of life receive non-beneficial treatments, which are often painful, uncomfortable, and futile, that have no hope of improving quality of life or improving their health while compromising quality of life. So Stanford University did a study a little bit ago, and they set out to determine if physicians and patients had a different meanings attached to the word treatable. So what they found was that patients in their healthcare provider or healthcare proxies would usually hear the word treatable and think about a positive message attached to the patient's future. So when they hear treatable, they often think that this disease can be cured or at least contained so that it does not diminish their quality of life. If the doctor also shares dire news about overall prognosis, patients discount it and come away with only hearing the good news of treatment. The study, though, revealed that when doctors use the word treatable, they often mean something quite different. So doctors say treatable when they don't want to say incurable. When doctors use the word treatable, they simply mean that there's treatment that can be applied. They don't mean to imply that treatment is likely to succeed or that if it does succeed, the disease will go away. They don't even mean that treatment is likely to prolong life. The chance that treatment could prolong life might be very small, and a doctor will still use the word treatable. The researchers concluded that the physician use of the word treatable may lead patients or their healthcare proxies to derive unwarranted good news and false encouragement to pursue treatment, even if the doctor has explicitly stated information to the contrary in the same visit. So this very unfortunate confusion over the word treatable can be avoided. People do want to make plans and treatment decisions knowing realistic benefits, burdens, and the full risk of any course of treatment. So research and evidence suggests that patient questions can be transformative. So they can help ensure that you get the end-of-life experience you want, that you can receive more complete information. It reduces the likelihood of painful and debilitating treatments. It reduces prolonged suffering, and it improves quality of life. Asking questions of your provider can also help change doctor behavior, and it can also change healthcare system behavior. So one of the tools that we have to help with this is our diagnosis decoder. So we have this on our website, and this is available if you have dementia, if you're caring for someone who has dementia, if you have a general illness, and then also for cancer. And so we created this tool to help generate specific questions that will help you get information that you want from your healthcare provider. So a few examples of some of the questions that might come up are, what are the possible short-term and long-term complications? Do I need to make a decision right now, or can I wait? And if I do decide to wait on pursuing treatment, what happens? Are there changes I can make to my lifestyle instead of taking this medication? And then asking, if the goal is to prolong life, what is the anticipated increase in life expectancy? How many months or years would you expect me to live if I were to do this type of treatment? And so now moving on to the end-of-life options, I do want to highlight that while we call this end-of-life options, it's not really about planning for your death. It's about planning how you want to live your life based on your values. So the options that I'm going to cover are not in any particular order, and they're also not mutually exclusive. So you can receive, some of them at the same time as you're receiving others. So you can always pursue all treatment options available to you. So you have the ability to choose all treatment options or choose to receive some treatment, but nothing aggressive. So for example, if you are seriously ill or terminally ill and you receive an infection, you may want to just treat it with antibiotics and not choose an aggressive surgery. You can also stop or refuse treatments. So you can make a decision to stop taking dialysis, discontinue medications that manage chronic conditions, stop blood transfusions, or forego treatments. So if you were to get pneumonia, you could always request comfort care, but not be treated for pneumonia so that you die naturally from the pneumonia. So palliative care, I want to highlight this about palliative care. So palliative care is available during any stage of a serious illness. So it's included in the end-of-life options, but just know that it's available as soon as you get diagnosed, and then again, any stage during it. So palliative care is specialized medical care for people living with serious illness. So this consists of a care team that will include a physician, social worker, nurse, chaplain, pharmacist, and other trained specialists. Palliative care is based on the needs of the patient and focuses on symptom management. And you can receive palliative care while getting curative care. So while you're still seeking treatment, you can ask for palliative care. So the care team will can also work with caregivers and provide education and tools. And this has been shown to greatly reduce stress and burnout for caregivers. So examples of palliative care can be pain medication or massages to help treat pains that may be caused by treatments, spiritual and emotional support, and physical and occupational therapy. So again, this option is appropriate for anyone of any age during any stage of the illness. Only 11% of people receiving palliative care are estimated to be in the last year of their life. Palliative care has also grown over the last 2 decades, and this can be found in most large hospitals and then also in some small hospitals. So most of the time it is found inside the hospital, but it is spreading to community settings and where patients reside. It's often covered by insurance, but depending on what kind of insurance you have, it may differ on what kind of services they will cover, as well as how long you can receive palliative care. So hospice is a service that provides compassionate care at the end of life. The patient's primary care physician or another doctor can make a referral for hospice following a determination that the patient is most likely to die from their disease within 6 months or less. And the goal is to maintain or improve quality of life. The majority of time when somebody enters hospice, they also stop receiving any sort of curative care. So the point is just really to provide comfort care at the end of life. It also involves an interdisciplinary team of caregivers and often includes doctors, nurses, home health aides, social workers, chaplains, trained volunteers, and others. So you can see how that gets confused with palliative care a little bit. So for those who have an appropriate medical referral, the cost of hospice, it will be covered by Medicare, Medicaid, VA, or other third-party insurance. And hospice can take place wherever the person resides, most often in the home. So sometimes people think this hospice is the place that they go to, but hospice can come in your home. So your doctors and nurses can come in your home. And again, we'll show you a resource that we have to help you find a hospice that will meet what needs you're looking for as well. Hospice also provides bereavement counseling, family support, and end-of-life planning. And then while hospice is available to patients with a terminal prognosis of 6 months or less, the vast majority of people are enrolled in hospice for far less than 6 months. So the average length of stay for Medicare patients enrolled in hospice in 2021 was 92 days, and the median length of stay was 17 days. And I think, President Jimmy Carter entered hospice, I believe, well over a year ago, and his wife entered hospice. Maybe it was like 6 months ago, and then she passed away 2 days later. So sometimes what happens in hospice is your hospice physician will, and your team will reevaluate the medicines that you're on and kind of adjust it. And it can really cause your quality of life to go up and also the length of time that they might expect you to live. Once you start receiving all of the comfort care and the additional services, that can actually extend your life sometimes. And so what people will do is they'll get referred to hospice with the 6-month prognosis. And then every 6 months, if you still live out that 6 months, you're reevaluated. And if they determine that, again, you're likely to die within 6 months, then you can get reapproved for hospice, which is, I'm not part of Jimmy Carter's care team, but that's my guess with what's going on there. So the next, again, I just really want to point this out because people get so confused with palliative care and hospice. I was at a palliative care conference and they said that most people, when they hear palliative care, they think about death, and that other doctors are afraid to bring in palliative care as the specialty clinic. So just because, if you are in there and they mention palliative care, that doesn't necessarily mean that you have a terminal diagnosis. This is just a serious illness where they can offer you palliative care to help with the symptoms that you have. And another really good example, my mother had breast cancer. And so sometimes when you're receiving chemotherapy, it can cause nausea. And so palliative care can be brought in to help you provide comfort for the nausea. So again, sometimes you get side effects from the treatment you're getting for your serious illness. So just want to highlight the difference between those two. And as I had mentioned, we do have a resource that we have on our website, and this is how to interview a hospice. So most hospice offer the same basic services, but they have differences in providers and differences in volunteer availability, nonprofit versus for-profit, their religious affiliations, how long they have been providing care in your community, and how supportive they are of end-of-life options. So we always think that it's really important. You can get this on our website, or if you call our end-of-life consultants, they can also provide this to you. But, it just is a list of questions that you can ask different providers to find out, what's important to you and if this hospice is going to meet your need or not. So palliative sedation, which is also called terminal sedation. So this is practiced in very rare circumstances, and it involves the individual being medicated to reduce consciousness while also stopping all nutrition and fluids. So typically, the person remains unconscious until death. Sedation may bring some relief for extreme pain and suffering. However, it may not totally relieve the symptoms. So, palliative sedation must be medically managed by a healthcare provider, and it's offered mostly in the hospital or a care facility. Palliative sedation is ordered by the patient's provider after carefully evaluating the patient's symptoms, disease process, and prognosis, and discussing it with the patient, their loved ones, and healthcare proxy. So, palliative sedation is different than sometimes people will say, like, oh, yes, my loved one had palliative sedation and they were given a bunch of pain medication at the end of life. So, palliative sedation is different than that. So, with pain medication, a person may drift in and out of consciousness. But with palliative sedation, again, the goal is to put them into a deep unconscious state until death, really trying to minimize the level of pain that they are feeling. And now I want to introduce you to our storyteller. Let me just 1 second to get her up here. There's Marcia. Okay, Marcia, if you want to start sharing your story.
Yeah. Hi, everybody. I'm Marcia, and I live in Mendocino up on the Northern California coast. And it's a pleasure to be here today. I became a storyteller for Compassion and Choices because my mom, at the age of 98, chose to voluntarily stop eating and drinking. And my husband Todd and I were her caregivers through her dying process. And this experience got me to think about the fact that someday I too will make this passage. I kept a journal of my mom's VSED week, and VSED is the acronym for voluntarily stopping eating and drinking. And I'd like to tell you a little about her and my experience. My mom's name was Opal Sloan, and she was born in 1918. She was practical, organized, curious about people and places, and always interested in learning new skills and expanding her horizons. And the way she planned her death was entirely in keeping with how she lived her life. In her late 80s and early 90s, my mom said many times she did not want to keep living if mental or physical challenges compromised the quality of her life or made her unable to choose how and when she wanted to die. At her senior residence, she joined a meditation group. She read about death and dying, and she took advantage of the resources available through Compassion and Choices, all leading to her decision that when she felt it was her time, she would voluntarily stop eating and drinking. In her late 90s, she started having more physical challenges. She gave up driving. Carpal tunnel syndrome made using her computer and holding a fork more and more difficult. Her appetite was decreasing. Her weight was dropping, and she could see that soon she wouldn't be able to leave her apartment. Life was getting more difficult, and it was not a surprise when at the age of 98, she announced it was time. My father had died 27 years prior. I was her only child, and my husband Todd and I were on board to help her die the way she wanted. We set her VSED start date for 3 months down the road, which gave my mom time to finalize her affairs and get organized for her VSED journey. For her memorial announcement, she wrote, "I have lived a long and happy life and feel I've come to the end of it. I'm thinking of my passing as a new adventure, wondering what will happen." She'd recently seen her doctor, who had written her a diagnosis of failure to thrive. When she asked him about VSED and how long the process usually takes, he estimated 2 weeks to a month, perhaps less for her. As it turned out, my mom's VSED journey took 7 days. Because she did not have a 6-month terminal diagnosis, the local hospice could not provide care, but she had the round-the-clock care she needed from me, my husband, and several relief caregivers. She had the support of the nurse at her senior facility and the commitment of her doctor, who prescribed sedation and anti-anxiety medications and signed the death certificate after she died. And most importantly, my mother had the strength of her own resolve. On her first day of VSED, Mom said that for several days prior, she'd been eating less and not missing food. She said, "I'm telling myself I don't need food and I don't need this world." And that day we enjoyed looking through family photos. On day 2, she experienced dry heaving, after which she felt better and slept and rested. On day 3, she seemed back to her old self, wanting to make sure her cable TV provider had discontinued her service. I played music CDs, and she especially enjoyed slow, spacious piano without a regular beat. And several days later, I played my cello for her as she drifted off to sleep. In the course of the week, Mom came up with several hand signs in the event she could no longer speak, signals for yes or no, and tracing her mouth with her finger when she needed her lips moistened. On the evening of the 6th day, eyes closed, she traced her lips for the last time, and the next morning she took her last breath. Before she undertook the VSED process, I could not imagine that anyone could dictate their death so much on their own terms. But she did it. And from how she described what was going on to her, what was happening to her that week, dying felt no better or worse than how we sometimes feel in the midst of life. I deeply admire my mother's courage and appreciate that I could witness the preparation, the clarity, and the fearless resolve that marked her choice. I see that knowing she could VSED when she was ready was tremendously empowering and reassuring for her. I came away from my mother's VSED week less in denial about my mortality, less afraid of the death of my physical body, and more interested in thinking about how to prepare so I'll feel ready when it's time. We may not all have the experience my mother did, but her story encourages me to think about my death with the same curiosity and openness with which I think about my life. And I hope her story can encourage others to do that as well. My mom's journal is posted on the Compassion and Choices website, and I will put the link in the chat afterwards. Next slide. In the last couple of years, I've shared my mom's story in several Compassion and Choices webinars. And Angela, thank you so much for this opportunity to learn more about VSED and to share information about VSED, which is illustrated by my mom's story. Voluntarily stopping eating and drinking is a conscious decision to refuse foods and fluids of any kind, including artificial nutrition and hydration, in order to allow a death consistent with the body's natural dying processes. The US Supreme Court in 1990 affirmed the right of an individual with decision-making capability to refuse food and fluids. So VSED is a legal end-of-life option available in all 50 states for people over the age of 18 with mental capacity. VSED can bring reassurance of an end to suffering for someone with a terminal illness or chronic or incurable disorder. Or as for my mother, it can bring a peaceful end to a long, well-lived life. The VSED dying process will be different for everyone, and how long the process takes is going to depend on factors like age, physical condition, height and weight ratio, current illnesses, fluid retention, ability to adhere to remaining completely free of all fluids, and readiness for letting go. Next slide. VSED is a patient-directed, patient-empowering approach to dying. A person decides for themselves when they will begin VSED. And if at some point after beginning the process they reconsider their decision and decide to resume eating or drinking, caregivers must honor that choice. VSED cannot be undertaken alone. A person choosing to VSED needs a care team of people supportive of their choice. Loved ones, family, friends, paid caregivers, an end-of-life doula, physicians, and hospice. Once the VSED process has begun, a person needs 24-hour care, including help with self-care, such as washing, being turned in bed, mouth swabbing, and ongoing oversight from their physician or hospice who can provide palliative care medications to help with anxiety, thirst or hunger, and end-of-life symptoms. VSED can be undertaken at home or in a care facility. For someone residing in a care facility, they will want to discuss their wishes with the nursing director or social worker to make sure they have their support. VSED is legal, but not every institution is supportive of this choice. Some care facilities consider food and hydration medical care, which a person can legally decline, while other care facilities consider food and hydration to be basic needs, and they may not be willing to support a patient's decision to VSED. Many hospices support VSED, but it's good to call the hospices in your area to see whether they would support you. If they don't support VSED or are not familiar with it, you can suggest they contact Compassion and Choices, the doc-to-doc line, where they can receive free, confidential information and mentoring for facilitating the VSED process from one of Compassion and Choice's national doctors who specialize in end-of-life care. Next slide. Other considerations toward planning for VSED include, if you haven't done so already, completing your advanced healthcare directive and choosing your healthcare agent, someone who will speak for you when you can no longer speak for yourself. Also speaking with your physician about completing and signing a POLST form, physician orders for life-sustaining treatment, where we can specify the types of medical treatment we would want to receive during serious illness. Completing a POLST is a very good time to speak with your doctor about your decision to VSED and make sure they're on board to support you. You may want to create a written statement or make a video stating your intention to VSED. A clear spoken statement can be helpful should anyone question your wishes or your decision-making process. Some people create 2 videos, one stating their intention and one for themselves, where they can hear their own voice reminding them why they have chosen to VSED, which could be helpful during the VSED process if you needed help recommitting to your decision. These written statements and videos all help confirm that the decision to VSED has been made by the individual themselves and is not an act of neglect or abuse by caregivers. Other considerations include completing all your financial and business affairs and planning for what happens after death, Would you prefer to be cremated or for your body to be buried? Do you want a funeral or a memorial? Also, researching items needed for the VSED process, a hospital bed, a walker, shower bench, incontinence products, or a bedside commode. And these end of life considerations involve communication with family, friends, and physician, and giving ourselves time, if we have it, to take care of our affairs can ease this process. You may also want to create a legacy project to leave behind for your loved ones, or to support a project or organization near and dear to your heart. Anything from creating a scrapbook about your life to writing letters of advice to initiating a grant program or starting a foundation or nonprofit. You might also enlist a family member or friend to become a storyteller for compassionate choices and share the story of your well-planned death. My mother did not enlist me to tell her story, but as a first-time caregiver for someone choosing to VSED, it was a life-changing experience that I've wanted to share. Next slide. And the last slide for me
Oh, go back one slide, Leslie, sorry.
Is this question, what would make this time meaningful? How long the VSED process takes will be different for everyone, but whether we're the person who's going to VSED or on that person's care team, thinking in advance about how to make this time meaningful is important, along with all these practical considerations. How do we want our last days to be? Do we want to listen to music, have fresh flowers nearby, or look out on a garden, have a candle burning, have visits with a chaplain, read or be read to, watch favorite movies, look through photo albums, spend time with loved ones, keep a journal of this experience to share with others? I found the time with my mom during her VSED week to be very poignant. She'd taken care of her affairs, she felt at peace, and that week turned out to be as much about living as it was about dying. Our conversations ranged from mundane to funny to riveting, and my mom, my husband, and I had a beautiful opportunity to appreciate the years we had together and say goodbye. Thanks, Angela.
Thanks. That's my puppy up there, by the way. I travel a lot for work and give presentations about voluntary stop eating and drinking. And so for me, I like to look up and see him when I'm traveling. So, but thank you, Marcia, so much for sharing. Marcia had said to me last time I had asked her to present with us, she was surprised that she got so emotional. And I think it's something that we're always going to get emotional over the loss of a loved one. And I know my mom still cries over the loss of my grandmother. But really to the point of, I have another presentation about advanced care planning, and the more you can plan ahead and share this with your healthcare proxy and your loved ones also helps with the grieving, and any sort of anxiety that comes after the death of a loved one. But you can always keep getting emotional, Marsha. I love it. So I love when you share your story. Thank you so much for doing that.
Thank you.
Next slide. So medical aid in dying is authorized in 11 states. So it is, 10 states plus Washington, D.C. And medical aid in dying is a procedure, a medical practice when a terminally ill, mentally competent adult who has a prognosis of 6 months or less to live can request that their doctor, or in some states, advanced practice registered nurses, give them a prescription to self-ingest medication to peacefully end their suffering. So everything in blue on here are the states where medical aid in dying is authorized, and laws in each state vary slightly, but the basic eligibility requirement is the same. So Oregon and Vermont, we also have a legal department. I think I had them listed on the slide in one of the first slides, but didn't really go over it. But so our legal department helped initiate getting rid of the residency requirements in both Oregon and Vermont. In Oregon, we worked with a doctor who was treating a patient or in Washington, right over the border. The doctor was in Portland, and the patient was right over the border in Washington. And medical aid in dying, as you can see, was authorized in both of these states, but the doctor wasn't allowed to prescribe to his patient. So we were able to remove the residency that way, and the state settled with them and just said go through the legislative process. We did a similar thing in Vermont, and they also said go through the legislative process. And so we helped run an improvement bill there, removed the residency, and the governor of Vermont signed that one. I do want to point out that if you have questions about this, you can always contact our end of life consultation line, but it would not be recommended that I live in Arizona, that I should travel to Oregon, get the medication, and return to my home state of Arizona. Medical aid in dying is not authorized here, and somebody can be charged with manslaughter. And so you would be putting your loved ones and the doctor at risk if you were to try something like that. And as you probably can guess, if you're terminal with 6 months or less to live, traveling can be very difficult. So while it's nice that they've removed residency, it can still be very difficult to access in that sense. So we keep trying to plug away at passing it in other states. And about 90% of people who use medical aid in dying are also enrolled in utilizing hospice. And we also know from data that's collected in the majority of states that about 36% of people who receive this medication never use it. Their loved ones, though, have come back and reported to us that they see an immediate change once the terminally ill person receives the medication. So one of our storytellers, also in California, her dad had been diagnosed with glioblastoma and had been given a prognosis of 4 months to live. And he was very, very concerned about developing, the severe headaches and the seizures. And it took him about 2 weeks to go through the process of getting the medication. And she said once he got it, like all of the anxiety left, and he was able to spend the remaining weeks of his life, saying goodbye to his loved ones, spending quality time with them. And he just wanted it in case the symptoms got so bad. And he never ended up taking it, and he just passed away peacefully in his sleep, which is exactly how he had wanted to go. And next slide, Leslie. So this is the last slide, and then we'll move into Q&A. So there are lots of ways to get involved in Compassion Choices. So if you haven't already, we encourage you to order our free end-of-life decisions guide, and this is available on our website. You can either go on the website and download it, but it is like 44 pages, or you can put your address in and we'll send you a free copy. So everything that we offer is free, as we're a nonprofit. And then we also cannot accomplish the work I mentioned early on, and Marsha is a volunteer, without the help of our amazing volunteers. So we work with volunteers across the country who share about Compassion and Choices, our resources, and inform their local communities about the importance of end-of-life planning. And then Compassion and Choices, as I mentioned earlier, is funded almost exclusively by individual donors like you who are committed to issues of end-of-life care and choice. And so when we go out and do presentations, we always put this in here, and just always, some people like to volunteer their time, and other people like to, give money to certain causes. I do both. So if there's an organization I really care about, I volunteer my time, and then other organizations, sometimes I donate money to. And then now we have about 15 minutes left for some Q&A. Oh, you can skip that slide, Leslie. You can actually stop sharing your screen too. We'll just go back to a big group. Does anyone have questions or comments? I see people thanking you, Marsha, in the comments, if you didn't see that.
I have a question.
Yes.
I'm in the process of changing my will and living will. How do I incorporate Compassion and Choices into my living will?
As far as for like donations stuff?
No, like how do I word it? And my living will, like, I have two questions.
Okay.
And my mother had Alzheimer's, she wasn't able to do that. But that's my second question. What about Alzheimer's when you don't have your wits about you? They say you have to know what you're doing when you take the injection.
Oh, are you talking about medical aid in dying specifically?
Yeah.
Okay. So I'm also going to give a different presentation on June 25th, just over medical aid in dying. Same thing,
Okay.
training the advocate that's set up like this. But for medical aid in dying, that cannot go into an advanced directive because you have to have full mental capacity at the
Right.
time that you're making
Right.
decisions. So
Yeah, I thought
go
they were
ahead.
trying to change it that you put in, should I have dementia? This is how I feel. And, and
No,
put it,
so yeah, so we have on June 21st, we're doing another presentation on our dementia values and priority tool. And that
okay,
will align with it kind of aligns with the PULSE. So if you're familiar with the PULSE, you get three options. And this is for somebody, a PULSE form is a physician order of life-sustaining treatment. Depending on what
okay,
state you live in, sometimes they call it a MOST, which is like a medical order, scope of practice or scope of treatment. Um, and so that will give you three options. And so the first option is that you want to receive all treatment. The second option is that you want to receive treatment for acute care, but nothing aggressive. And then the third option will be that you don't want to receive treatment and just do comfort care. So that's a
okay,
tool that we came up with for people with dementia that you would fill out while you still have your decision-making capabilities.
right,
And
right,
yeah, so that one will go over on June 21st, but thank you for being aware of that one.
okay. And the other one is June 25th,
Yeah, the
did
medical
you
aid
say?
in dying will be June 25th. Yeah.
Okay, so I have to call my lawyer and see, I have the living will. I thought of just incorporating something, for the person in charge to say, I am an advocate of compassion and choices, and maybe put their number, please contact them. Would that be something? I don't know.
So I
You know,
no,
for,
no, do you have a healthcare proxy?
yes,
Yeah, so that your healthcare proxy should be the person that knows exactly what kind of treatments you want and don't want if you're not able to make decisions for yourself.
oh, okay, so I don't have to have it in the healthcare proxy. I can just let her know, right?
Yeah, just
So,
tell your healthcare proxy. The most important, it's really good to document your wishes, but the most important thing, and I hear this all the time from hospice social workers and hospice nurse, is to have conversations with people about what you want at the end of life. Because that's people
okay,
tend to remember the conversations more than
okay,
thinking, oh, where's this document? So
okay, okay. But it's all right, in case you forgot, to just say I'm an advocate of compassion and choices. I could put that someplace in there,
So
and
if
then
you
she'll
put that
remember.
in your if you put that in your living will, so just to clarify, a living will is a document that you fill out when you're no longer able to make your own healthcare decisions. So
Right,
putting that you're an advocate for compassion and choices won't give them much direction at all. So,
okay. So
so
there's
because
nothing
we
I
do
can
so
put in,
much around end of life.
yeah, okay. So there's nothing I can put in right now, just let the person know.
Well, you can put in there for your living will, it will usually say if you want to receive different life sustaining treatments. So do you want to be on a ventilator? Do you want to receive food? So
Right,
you'll want to mark those kind of options. And then when it says like sometimes living wills will say, do you want to put additional information in there? So you might want to say like if pain is something that's a priority for you. So some people at the end of their life, if they're in a lot of pain, or they will be like, I don't want to feel any pain and say, give me as much pain medication as possible. And that way they know to provide that to you. Where other people I've talked to say, I want to, I understand I might be in pain, but like minimize the discomfort. That way, in case I'm able to have any sort of like come back into conscious, I'm able to say my goodbyes and kind of known. So you can kind of outline different stuff like that in your living
okay,
will.
Yeah, no, I was meant about, how you end your life with the injection now, I guess it is, instead of a pill.
It
Um,
is, so it is not an injection. It is medication that usually people will ingest through like drinking it the
uh,
majority of the time.
okay. All right. Yeah, I was just wondering how to, put that, because I'm afraid I'll just have to write it down for her and tell her to contact them. Yeah, like if I have less than 6 months to live. So,
Yeah, but if you have less than 6 months to live and you still have decision-making capabilities, you can request it. Your living will
okay.
goes into effect once you no longer have the ability to do it.
Okay. All right. Thank you. I'll be tuning into your other two podcasts.
Okay. Yeah, I put the links in there. If you saw, somebody asked me to put the links in there. So I put the one for June 21st on there, which is the dementia one in chat. And then I
Okay.
also put the one for medical aid in dying in there. And then when you
Uh,
get the follow-up email, there will be a link to all of our events and you can go that way and register too.
Okay, that sounds good. Is this going to be repeated if you missed it? This
Yeah, I repeat them.
podcast? Okay, because a friend of mine, a girlfriend wanted to know that so she could listen to it. So, okay, so I'll tell her to contact you with her email, right?
Yeah, she can just go on our website and sign up for it.
Okay. All right.
Okay.
Thank you very much. All right.
Yeah.
Bye-bye.
And then Sarah, I think Sarah Fleming.
Yes, thank you for this presentation. For the VSED, I think I understood that you said hospice will not get involved with that. After 3 or 4 days of no nutrition, would the organs begin to fail that would justify a hospice involvement to help with morphine at that time?
Angela?
Yeah,
I'll
Marsha.
just mention the experience with my mom was that that is definitely a possibility. That I understand that what you just said, that after a few days you may qualify for a 6-month
Right.
terminal diagnosis that you might not have at the outset of your VSED process. And maybe it was just the timing in this case. The hospice volunteers, or they came to take the medical tests on maybe a Tuesday, and she was in her labs were too good for her to enter hospice. And then they came again, I believe, on the Friday, and they were still too good. I mean, it's kind of unbelievable, really. And then it was the weekend, and then she died and then it was too late, basically. The weekend was there and they weren't going to come again. So I do believe that in the most cases what you said is true, but in the case of my mother, it wasn't.
Thank you.
Judith? Judith, do you have your hand up?
He's muted.
Yeah, I was trying to ask her to unmute.
Okay, how's that?
Okay.
All right.
Good.
I'll make it really short. I started a small group in a church many years ago when we got together once a month to do all of this work. I now moved into a continuing care facility, and I mentioned it to the executive director, who referred me to the social worker. We've not really gotten very far with it. I'm not sure if I'm just kind of being put off on it, or, I'm not sure. But what kind of things can I do at this facility? I have some ideas, and I've also registered as a volunteer so that I can, get more information about things. But what kinds of things can we do in this type of facility to spread the word, or should it be one-on-one with people maybe that I know?
So is your question that you want to ask, like, if you could do a presentation at the CRRC? At the community?
No, I'm not sure where we're going with the idea. But I'm not sure whether we should do, I could just talk to people one-on-one that I've known, or whether we want to there's 390 people here, so I don't see
Mhm.
that it's a very, that's what's bothering me. It's too many people to get together and stuff, and I'm not sure how to organize it, and they haven't come with anything yet, so thought you had any ideas.
Well, I know that so some facilities, again, I would also check with your facility, like the nurse administrator, and see kind of if they have their own policies about end of life options there. But some people, we have a lot of people that are in community living, like whether it's independent living or assisted living, and they come up
Right.
with like their own groups, like four of them, and one of them is called, I'm trying to think what they're called. It's such a cute name. They call themselves the Help Committee, and it's like honoring end of life planning. Um, and that committee just meets, and then they come up and start, asking people to join by Zoom. And the community living helps them by like sending out, posting flyers that this presentation will be available. But yeah, you can also just meet one-on-one with people, whatever makes you most comfortable.
Okay, I think I've decided the two larger groups, so I'll just start with people I know that are, okay with this, so.
Yeah.
Not small and just do kind of what I've been doing.
Surprisingly, I think I don't think it's surprising, but what I hear from volunteers all the time is surprisingly more people want to talk about this than they thought. And I don't think
Yeah.
that's surprising just because I do this for a living. And so I'm
Yeah.
used to talking to people who want to talk about this. But most of the time people are like, oh, I brought this in and I didn't think people were going to want to talk about it. And like we had over 100 people show up, so.
Yeah, could people from the agencies do a presentation here?
Yeah.
From the Northeast area?
Yes, for sure.
Okay, all right. That's one thing I might pursue.
When I send out the email, if you just respond to the email too, then it'll get forwarded to me and I'll connect with you on that.
When I send what email?
We're going to send out a follow-up email with the
Oh, okay.
PowerPoint and stuff, and you can just respond to it and it'll get forwarded
Awesome.
to me.
Thank you. That was great. Thank you.
Other questions? I did have a couple questions about people wanting to share their story, and I put in, well, first, before I lose this one, somebody did mention about bringing up the documentary of Take Me Out for Feet First. If you have Amazon Prime, it just went on there. And one of our supporters in California was the director, and it's a documentary. There's 6 episodes of people, at the end of their life, and them like speaking about why they're choosing the options that they're choosing or why they're advocating for it. I think we had some people from Minnesota on here, and Dana Nelson. Oh, Dana. Marcia knows Dana and Andrew. The first time I met with Marcia, it was so sad because she did a storyteller like a workshop, and Andrew was 34 when he died, and Dana was 27, I think, or 26. She died from cancer in Minnesota. And Marcia was just, again, we were talking about this right before. It doesn't really matter how old you are. It's always important to plan for end of life, because Marcia said it's sad that the people that were so young have now died, and I'm still here, so both Andrew Flack and Dana Nelson have their own documentary in this Take Me Out Feet First. And then a couple people asked about sharing their story, if they have a story that they want to share, and you can do it. I put the link in response to somebody, but I also just put the link in there. You can click on that and share your story that way. And you can just kind of write in there what, like a brief, overview of it. And then we have a storyteller program, and one of the staff from the storyteller program will contact you and get more information about it. And then you can select, do you want to, if you want to put it on our website, we can put it up on our website. Sometimes you share it on Facebook, however you want us to help you share it is how we'll share it. Somebody also asked about the difference between us and Death with Dignity. And so we are a much larger organization than Death with Dignity. We focus more to like grassroots. and Death with Dignity, they have their own staff that will try to pass legislation, where we work with volunteers to go out and try to help pass the legislation. But we do work in partnership with them. But then we also, their sole focus is getting medical aid and dying laws passed. And our focus is also on the entire end of life experience and trying to change the culture around end of life so that people have a better end of life experience. Any other questions? If you're raising your hand and I can't see you, let me know. Sarah, I see you.
Yeah, I wanted to give time for anybody else who hasn't spoken. Yeah, I'm concerned about a very likely diagnosis of dementia. But, and from my mother's experience, hers was not a fast death. It was 12 years. So do you have any advice to me on how to, if I were to get the diagnosis, I want to have my plans in place before that happens. What would be an efficient way to start get the plans going, whether it be suicide in Switzerland or medical aid in dying, although that's not, dementia is not a terminal diagnosis. If so, it's not fast enough for me.
So for medical aid and dying, I do just want to clarify that when you have a diagnosis of dementia, you can still have decision-making capabilities for several years. So just having a diagnosis of dementia alone will not make you eligible for medical aid and dying. But if you have another serious illness on top of it, even if you have a dementia diagnosis, it doesn't necessarily mean that that is an option that's ruled out for you, as long as you still have your decision-making capabilities.
Oh,
In like some of my coworkers, one of my coworkers, her mom was diagnosed with dementia and had a similar, her grandmother died from dementia, and it was really long and not an experience that her mother wanted. So when she was diagnosed with dementia and she still had decision-making capabilities, her mom went through the voluntary stopping eating and drinking process here. And my coworker supported her. And similar with Marcia, like once her mom started the voluntary stop eating and drinking process, she then became eligible for hospice. So again, depending on what else you have, if you only have Alzheimer's and you're otherwise a healthy, 80-year-old, the visa process might take longer, but if other things are going on, it might take shorter. And then, as I mentioned, we're going to go over the dementia values and priority tool. And that has been, that's a tool that will list out, it has markers for you, but you can also add your own markers in there. So what they did is they talked to people about what would be a point where you would not consider your quality of life if you had dementia to be what you want anymore. And so some people said moving into a nursing home. Some people said if I'm no longer able to bathe myself or feed myself. And so it has those markers, and then you select which option you would want. If you, want to receive just comfort care or want aggressive care still. And then you can also put your own markers in there. So it could just be even the diagnosis of dementia.
Okay, or I don't recognize my sisters.
Yeah. I heard the other day somebody said that they love music, and music is really important for people that have dementia. We have a lot of like dementia cafes, and they play music, and it really can bring joy to people living with dementia. And she said, if I stop responding to music, that is my line in the sand.
Yeah.
So,
Okay. Thank you.
yeah. Marcia?
I found the resource, the book Choosing to Die by Phyllis Schachter, a very helpful resource for understanding how dementia and VSED can work together. She describes the process of her husband, his choosing to VSED and staying ahead of the dementia diagnosis. It was really clarified for me how that can work. Choosing to die. Mm-hmm.
Okay, thank you.
We also have a storyteller that wanted to do a video of it, and she was in Minnesota, and she did VSAD when she was diagnosed with dementia. So I was trying to see if I could find it real fast to give to you. But if you're free on either email me or if you're free on the 21st, we'll highlight this information as well, Sarah. So
Okay. Thank you.
yeah. Any other last questions? Can you put, hold on, let me get. I see somebody asked for the book in there. So I'll put it in Amazon here. Let me put it in here before I close out so you can grab it. Okay, I just put the link in there for choosing to die. Judith, did you have another question?
I just wanted to make a quick comment. We also have memory care here at our facility. And a friend, neighbor was in assisted living for a while and not doing well. And I thought, we mentioned books or reading, and I said, I love to read out loud. She said, oh, I would love to be read to. I did that the whole week before she went to memory care. It just absolutely changed things so much at that point. It was, and we had a wonderful time every night. So I just wanted to pass that along.
Thank you for sharing that. I hear that too a lot with the VSAD process. We had a gentleman in Oregon who had ALS who decided to do voluntary stop eating and drinking. And he called his brother and his wife and his kids. And he said they all just gathered around and stayed with him. And it was just like a wonderful week of saying goodbyes versus, you know, getting that phone call and hearing, you know, this person died because they fell, you know, and then they don't get to say that by it. It can add an additional level, I think, of closure sometimes. Somebody did comment on that there's a lot of females here, and we see that a lot in compassionate choices.
Yeah.
But thank you to the men. I see you, Carl, for joining. Any other questions before we hop off? Or oh, it was so nice meeting you all. And you'll, like I said, you'll get an email with this presentation recorded along with the PowerPoint. So you'll have all the information that we went over. And then feel free to respond to that if you have any questions for me. It won't go to my email, but it'll go to somebody who can forward it to me. So thank you all.